to lead us through the next 90 minutes. Dr. Root's an associate professor of special education in the School of Teacher Education at Florida State University, and affiliate faculty with the Florida Center for Research for Reading. She teaches courses on evidence-based practices for supporting academic and transition outcomes for students with disabilities. Dr. Root is a board-certified behavior analyst and the director of the General Curriculum Access Lab at FSU. Her research focuses on instructional methods to promote meaningful academic learning for students with autism and intellectual abilities. She's just coming off a very successful session at the ACE conference, and we're excited to have her here today and throughout the rest of the 5-part series. With that, I'm going to turn it over and control of the screen to Dr. Jenny Root.
Hi, everybody. I am really excited to talk with you all. And I'm really grateful to ACE of Florida and Department of Ed for allowing this to be a 5-part series. So while you certainly don't have to enroll and attend all of them, very much encouraged to, and I'm hoping that the information builds across these months. So today we're going to be talking about supporting adult learners with disabilities, with the goal of being that you get a general overview of the characteristics of the adult learners you may have in the classroom. And then also, how can we make sure that we have a strengths-based approach to working with and supporting these adults? Okay, so while I'm getting started, I would love to know who you are. So if you'll put into the chat your name, where you are, and then what your professional role is. And if you're an FSU alum, whether that's within the College of Ed or another university, I would love to hear that also. So again, I'm Dr. Jenny Root. I'm currently coming to you from Tallahassee, from North Carolina. And as we said, I'm an associate professor of special ed here at Florida State. So I want to start by thinking about what barriers have you observed for your adult learners with disabilities? So just thinking about the students that you've had in your classroom or you've had in the past who've had difficulties, and whether they have an identified disability or if they're just you weren't aware of what their disability was. Thinking about what barriers is a helpful framework to begin with. Because we then want to think about what solutions we can come up with and how can we make the students successful within the environments that they're in, right? So we certainly want to build up individual skills, but we also want to think about what barriers might there be in the learning environment that don't have to be there, right? Is there a fence that maybe we could remove? So it's important that we also begin by thinking about what is intelligence. And I think this is an important sort of framework to begin with, where it's important that we know there's not a correct definition of who is intelligent or who is smart. It's an extremely abstract concept that describes a set of behaviors that can be measured at one point in time. And those intelligence tests measure things like abstract thinking, reasoning, judgment, making decisions, adjusting to the environment, such as changing the volume of your voice when entering a library. But we can't directly measure, like what is happening and what somebody's capacity is for this. And so many of the assessments that we use in determining the presence of a disability, we have to know that based on their performance on specific tasks and their flaws. In those tasks, it's certainly one measure that can tell us about an individual, but we don't want to solely rely on intelligence tests or much less any other type of assessment to perhaps set artificial ceilings on what an individual is capable of. So, for example, we may be able to, by these assessments, determine what somebody's abstract thinking is, but it's based on, are they able to identify patterns and shapes and copy those patterns using blocks, right? That's the assessment task that we're trying to then generalize into their general performance. So next I want to focus on what are some disability characteristics or some characteristics of some disabilities. Certainly saying that in 90 minutes, I cannot be fully comprehensive, but my goal is to give a general overview of what some of the characteristics are of adult learners with disabilities that you may see in your classes. So these are, again, I said some of the disabilities that we're going to talk about. So speech language impairments, specific learning disability, intellectual disability, emotional and behavior disorders, ADHD, and autism spectrum disorder. You may have individuals who you're not even sure what their disability is, or they may not have ever been identified. You may also have some who, don't fall in one of these categories. For example, a traumatic brain injury resulting from a vehicle crash or a worksite incident, where an individual then has an acquired disability. But these are the few that we can cover in the time that we have. So beginning with speech or language impairment. So I want to break out what that means. These individuals may have a speech disorder. And so this would be one of the visible disabilities or a disability that becomes obvious, right? So if someone has a fluency disorder, so they may stutter on certain words or certain sounds. This could include an articulation disorder where they may have trouble saying certain sounds, or a voice volume issue where maybe they have more difficulty with flexibility of their speech or the volume at which they talk. Language disorders then can be seen as expressive. So their ability to use language to communicate their thoughts. So in a classroom setting, this would be their ability to show what they know. So you may have individuals that you've experienced where if you give them a task, they can do it and demonstrate their learning that way. But if you ask them to explain why or what they did, they may have more difficulty. That can also be a receptive language disorder. So understanding the language of others. So taking in information is where they may have difficulty. And then aphasia is going to be a really severe language disorder where it's difficulty with word recall. The causes of speech or language impairments generally aren't known. It's often comorbid. It means it happens at the same time as another disability. Often individuals with learning disabilities, as I'll talk about in a minute, may also have speech or language impairments. Intellectual disability, right? We know individuals with Down syndrome are often going to may have some difficulties, and it's because of the formation of their bodies or their mouth. Autism may have a speech and or language disorder as well. So often this is going to happen sort of together. But it's important to know that speech and language don't just impact our expressive communication, receptive communication, as if like that's a thing in isolation, right? So as I said, communication is how we show what we know. It's how we receive information, and that's going to impact our performance in an academic setting, as well as in a work site setting. So there are many different sort of disorders or disabilities that are related to speech and language. So you can see here it's got listed, you may have a speech sound disorder if you have some articulation difficulties, or maybe you have those oral facial structural deficits. You could also have a fluency disorder. Again, that's we would commonly call that stuttering. But you may also have just a language disorder associated with a biomedical condition, autism, Down syndrome. But then we have this group of individuals that really the science of reading is helping us understand and identify them better. And they have a developmental language disorder. And so that's where you may have difficulty in things like syntax, the use of words, morphology, semantics, word finding, discourse and talking, verbal language and memory, as well as phonology. Any of you who teach reading know that all of these things are impact reading as well. And so some of these individuals may also have a learning disability, or may be identified as having a learning disability, or perhaps because you have adults were in the past, right? They may not be aware of what a developmental language disorder is, especially if they're older adults. But you might see some of these difficulties that they have, and you should be aware that you're probably going to see it in their reading and writing, but it's actually related to their language. This developmental language disorder, here's, and I realize now the colors are difficult to see, but I like this graphic because it shows you some of the other areas that are impacted. So speech sounds, perhaps learning and memory, like difficulty following multiple step directions, because that requires holding multiple things in your working memory. Um, Social language, so having conversations, missing social cues, being able to adjust the words, the tone, all of that based on the situation. Discourse, so if they're telling you a story or explaining how they did something, it might be kind of difficult, or they might jump around as far as things being out of sequence. The sentences, it might be a grammatical difference. And I'm not saying, this has nothing to do with dialects, right? We all have different dialects and different speaking styles, depending on where we're from and or the community we grew up in, right? And so it's important that we don't confuse dialect for disability. And then words, we might have difficulty recalling words, understanding new words. The vocabulary might be, there might be a smaller pool that they're drawing from, which is going to impact them academically in their writing and in their reading comprehension. So as I mentioned, a developmental language disorder, they may be considered to have a specific learning disability. So if they had an IEP in school, or if they're receiving accommodations, it might be based on this eligibility category. So a specific learning disability is a disorder in one or more of the basic psychological processes. And these individuals may have difficulty with attention and memory, thinking and reasoning, our metacognition, which is thinking about your own thinking. So sort of being aware of that. It's also going to often impact their social and emotional functioning, either because they're having difficulty maybe with the language and their expressive communication, but also, especially once they become, adult learners who have not had success in K-12 schooling environments, they're bringing with them a lot of that emotional baggage. And they may also have difficulty with generalizing information or skills and transferring them among different settings. We really don't know what specifically causes a specific learning disability, right? We do know that twice as many males as females are identified with a specific learning disability. And I used that term, that word identified, very intentionally, because it doesn't mean that twice as many males have it. Like there's not something about that we know of, that I'm aware of the science on. It's like the male brain is just different in this area, but rather we often across the board identify more males with disabilities because of the way that it presents and our societal expectations for women. We do know that some causes are organic, so just brain differences. They are often genetic. So if you have a parent with a learning disability, you depending on what the specific disorder is, you may also have children with that. And we know that our environment impacts our learning abilities. So things like having a poor diet and nutrition, especially during the developmental years, is going to impact brain development, as well as the prenatal and postnatal exposure. So things like lead poisoning or drug use during pregnancy. So the way I like to think of specific learning disabilities, and part of what makes it difficult to know everything there is about them, is because really it's an umbrella. Right. So it's a umbrella label that we use to identify individuals for services, either at the K-12 level or even in adult ed. And so under this umbrella are things that impact basic psychological processes, their understanding and language, and the way individuals receive, process, and recall information. It might specifically manifest in one of these ways. These are those psychological processes. So it could impact reading. So if it's becoming more common sort of in the popular press with the science of reading and dyslexia laws across states. So dyslexia is a specific type of disability. Relatedly, writing. So some individuals may have dysgraphia. spelling, which, makes sense as far as what we know about the relationship between decoding and encoding. Your ability to decode words is going to be your ability to encode, your ability to spell is not going to be too much above that reading level because of that relationship. Could also be specific to math and then language. And so individuals could have difficulties in all of these areas or just one. And that's what makes individuals so unique. That's part of what I love and why I got into special ed is I love those individual differences and tailoring things. It also can impact auditory processing. So being able to take in information that you hear, visual processing, being able to take in the information you see, sensory motor planning, as well as I mentioned, your social and emotional state. So intellectual disability is the next disability I want to talk about. And so it is determined based on an IQ test. I could go on a whole tangent about how they are flawed and come out of a racist and eugenics history, but they are what we have right now. And I'll put some of those resources if you're interested in learning more when I share the presentation resources. So we do know that intellectual disability represents a wide spectrum of individuals. And so it's categorized in sort of different buckets, individuals with what's considered a mild intellectual disability, moderate, and then severe and profound. Before about 2004 to 2008, these individuals, the common term was mental retardation. And that is no longer an accepted term. So we don't say that an individual is retarded. For example, they have an intellectual disability. You may also hear the term cognitive disability. It's actually a federal law. And then Rick Scott also made it the state law that we don't use that term anymore and that we replace it with intellectual disability. It does impact, depending on the severity, a wide variety of mental processes. So whereas a specific learning disability is generally going to just impact those areas that I mentioned before, intellectual, and it may have sort of an uneven profile. So if you have an individual with a math learning disability, for example, dyscalculia, they may have difficulty with recalling math facts and seeing patterns and things like that, but they could have average reading ability. Intellectual disability, while there still might be some splinter skills, it is going to be more across the board, some consistent skills. And really, it needs to be that cognitive, academic sort of aptitude, as well as daily living or adaptive behavior. So that would be like knowing when to call 911 in an emergency, or understanding, food safety of, if you've left milk out on the counter, we wouldn't drink that the next day. So adaptive behavior, those skills that we expect, it's culturally and society seen within the society for that age. So what would we expect of a 7-year-old, for example, in our society? An individual with an intellectual disability would not have those same sort of daily living skills. And that would be different from what we would expect of a 35-year-old, for example. As far as what the causes are, there are over 350. So you can't learn about them all, but it does kind of break down evenly into genetic, so conditions that individuals are born with. About a third are related to maybe external trauma or toxins, and then about another third is just unknown. So some of the prenatal conditions are things like Down syndrome, Fragile X syndrome, and fetal alcohol syndrome. Fetal alcohol often presents very similarly to ADHD or autism. And so we think it's probably one of the most prevalent causes of intellectual disability, and yet one of the most under diagnosed or identified. We also can have intellectual disability can be caused during the perinatal period, so during or shortly after birth. For example, being born extremely premature puts you at a risk for intellectual disability. Having a stroke or some sort of traumatic birth where there was a lack of oxygen to the brain can cause cerebral palsy, which often, but not always, includes an intellectual disability. And then there's the postnatal, right? So encephalitis, things like having a very, very high fever for a long time. Luckily, from my perspective, our vaccines can help protect individuals from this. And then there can be biological and environmental causes. Again, I want to keep in mind that IQ tests measure how an individual performs at one point in time. They are culturally and economically biased. Scores can change, and the testing is not an exact science. What it does tell us are things like the rate or the extent of learning. Not that an individual is not going to be able to learn, but at what pace and what depth. Their adaptability to situations, ability to generalize and transfer knowledge, and then problem solving skills. So the way that we categorize intellectual disability is based on the bell-shaped curve of intelligence, right? So if we consider average, it's hard for me to not use quotes a whole bunch. I'll put my hands in the lap. If we consider average about an IQ of 100, then based on this bell-shaped curve, about 34.13% are going to be up from 100 to 115 and another down to 85. So all of this is considered average. One standard deviation above, so about 13% of our population, is going to have this slightly higher IQ. They're not considered gifted, but may have a slightly higher, a faster rate of learning and depth of knowledge. Similarly, individuals who have an IQ between 70 and 85 do not have an intellectual disability in the way that we currently categorize it, but rather they might just take longer to learn. They might just be slower learners. Again, not at all putting a ceiling on someone's abilities, but just realizing sort of where they are in comparison to all of us. And it's these individuals who have an IQ less than 70 that are considered to have an intellectual disability. You notice they are at this end of the curve. We have about the same proportion of individuals in theory in society who have an IQ above 130 and are considered gifted. So again, we have ranges of intellectual stability. Those with a mild intellectual stability, which you are likely to have in adult ed, they usually are not identified until school age. Unless they have a genetic condition or some sort of physical disability, it's not until really learning begins that they may be identified. These students are going to master many academic skills when given high quality instruction and opportunities. And most are going to be able to learn job skills well enough to support themselves independently or, perhaps semi-independently. A lot of what impacts independence is not just economic, but also like safety and what they have learned as far as reasoning and judgment. Individuals with a moderate intellectual disability are going to show significant delays in development during those preschool years. So often we are going to identify them, especially with child find advancements. And as they grow older, those discrepancies in those adaptive as well as cognitive skills is going to widen, right? But with high quality instruction, they are going to be able to learn to read, to do math, communication, daily living skills. Then individuals who are considered to have a severe to profound intellectual disability, you're going to be identified at birth, or this is going to be a result of some sort of trauma. They're likely going to have significant central nervous system damage, likely to have complex healthcare needs, but with high quality and intensive instruction, can develop communication skills in the vast majority of the time, and perhaps some emerging academic skills. So the next disability that you're commonly going to see is an emotional behavior disorder. So this is extremely subjective and culturally dependent. And it's a bucket, a category that we put people in, but there's a lot of heterogeneity within that. So there's going to be a range of severity with either temporary or permanent conditions, right? So this could be individuals who have mental health concerns, depression, anxiety, OCD, schizophrenia, or bipolar disorder may fall in this category. So they're going to have sort of the three things we look at the K-12 level to identify somebody with an emotional behavior disorder. Is going to be the way it impacts their social behavior. So the way that they're able to develop and maintain relationships. They may be less mature or have just inappropriate social skills, and they may display some negative attribution. So, assuming that it's everyone else's fault, what is happening to them. So they're going to have more of that external locus of control. That like I don't have any control over what happens to me. I'm a victim, versus more of an internal locus of control of understanding, that my actions impact. Consequences and sort of my life situation. Again, there's going to be some affective characteristics such as depression or severe anxiety disorder, phobias, and psychosomatic disorders that can be treated with different medications, but are often sort of lifelong. Academically, they may function significantly below grade level. And then, therefore, many might leave school for a variety of reasons, not complete their K-12 education, and be in adult ed. In the K-12 world, when we look at the numbers of individuals with EBD, the boys outnumber the girls in our identification. Often this is because of the way that it manifests. So in special ed, we categorize behaviors as externalizing and internalizing. So our externalizing behaviors are those that I can see. It's getting out of my seat, putting my head on my desk, yelling, having a really low distress tolerance. With girls, often they're going to have more internalizing behaviors. So you may not see that irritability and anxiety. It might be kept inside. And so girls are often under identified. And in our society, often it's those whose behavior impacts others that get identified and supported, versus if it's only impacting themselves, they kind of go under the radar. There are some known causes, so biological conditions, schizophrenia, autism, Tourette syndrome, for example. We know, based on everything we're learning about trauma, and things like their ACEs score, so that can impact this as well. Failure to accommodate individual needs, having inappropriate expectations and inconsistency in that can also contribute to these difficulties. So, as I said, that it's individuals with emotional behavior disorders often are below grade level or struggle academically. But if you notice, none of these characteristics related to cognitive ability, reading ability, memory, and things like that. So then why are they struggling in school? Well, it's what we call the cycle of failure. So often the class work is difficult, or just on your faces to working in class. So being in the in a learning environment can have difficult social demands, academic demands. We may have difficulty with self-regulation. And so what happens then, because we have low distress tolerance and limited social skills, these students may display a challenging behavior. And again, these are those who have those externalizing behaviors. Well, what often happens is the students are disciplined, they're removed from class, they're suspended. Well, they're missing they're missing content now, and nothing's being done to actually increase their capacity to be successful in that environment. And so then the cycle just continues. ADHD is the next disability that I want to talk about. And I think it's one that maybe out of all of these, we have the most misconceptions about. I myself am included in that, as I'm continuing to learn and realize what stereotypes or misconceptions I had about ADHD. So the precise cause is generally unknown, right? We can't do like a blood test for it, or there's no cure. It's a difference in the brain. What we know is there's an imbalance of neurotransmitters in the brain. So the dopamine, the thing that makes us, the chemical that makes us feel good, and get like reinforcement from things, as well as noradrenaline. And there's just not enough available. So the stimuli then are poorly filtered. And so sometimes ADHD is seen as this inability to focus, but I like to think of it as focusing on too many things, right? It's not that I can't focus, it's directing my attention to what I need to focus on at that time. And I'm saying this as an adult woman who has been diagnosed with ADHD. And so I'm learning a lot about misconceptions and what it looks like in a wide variety of people, not just young boys, because our diagnostic criteria is generally based on that. So we know that it's very genetic. So 50% plus have parents or siblings with ADHD. There are also some non-genetic causes, premature birth, alcohol and drug consumption during pregnancy. And then there can be some psychosocial factors that I say encourage development of symptoms. So not that cause it, but that maybe exacerbate the behavioral symptoms. So not having a structured daily routine, high media consumption. It's not at all saying that the screen time causes ADHD. That's false. But high media consumption can exacerbate symptoms because, as I said, ADHD is related to dopamine. It's the like hits of reinforcement that we get in our brain. Life in classrooms, as like hard as we can try as educators, it cannot compete with the dopamine of TikTok or of a video game or of YouTube, especially like being able to scroll through multiple things. We know from early childhood research that the impact of screens it's not just the screen, it's what are you doing on it. So there's a difference between like watching a movie and scrolling through TikTok or YouTube, because it's like dopamine hit, dopamine hit, dopamine hit. And we like that. It feels good. We like that. That is my last 30 minutes before I fall asleep every day. But it then becomes hard to maintain attention and focus and stamina in an environment where you're not getting those immediate hits. Lack of exercise, because we know that exercising, especially high intensity cardio, can be really great for managing the symptoms and the way that ADHD manifests. And then there are neurobiological, there are just simply those structural abnormalities or differences in the brain. So those of you who've kind of been around for a while know, just like in education, things in psychology, we change terms and we change names. So it used to be we would say, well, do you have ADD or ADHD? Well, now it's one thing, and we have it in two categories. So inattentive is one type, and these individuals may have trouble concentrating because they just start thinking about other things. I call it having too many tabs open in my brain, right? So doing this task is going to make me think about this task and make me think about this task in my brain. It's hard to maintain attention. And so then that's going to impact planning, organizing, finishing tasks on time. So I wonder if any of you are thinking about specific students or family members that you've worked with, that this is the case, right? So they may have a big project or a task to work on, or even just something that takes a lot of steps. A friend of mine called this too many clicks, right? So because so much is digital now, especially post Zoom, we have a task that just takes a lot of micro steps. Using a personal example, travel reimbursement, right, for our jobs, or filling out forms. It's not just doing the form, it's downloading it, saving it, filling it in with the right information, which might require me to open Google Maps and see what was my mileage, and then finding this receipt, and then putting them all together and saving it and sending it. So I don't see that as one task. That's like 12 tasks. And that inattention can make it difficult. It can also then make it difficult to learn new things because you have to maintain attention. The second subtype is hyperactive. Sometimes this might look like an inability to sit still. So if we think about our young children or even other adults who might be moving, getting up and getting out of their seat, like big movements, rocking back and forth in their chair, leaning back in their chair, right? Unable to sit still. But for many of us, this also might just look like I'm always tapping my leg, or I fidget with something on the desk, or I'm going to twirl my hair, right? So a lot of us have this impulse to be constantly moving. They might be restless and fidgety, but that can be external or internal, right? So I could look like I'm having a conversation with you and I'm listening, but I internally am thinking about all these different things. I have that too many tabs open in my brain. And so you can have primarily inattentive type, primary hyperactive, but you can also have combined where you get all the flavors, which is me. And so I'm bouncing from one activity to the next, and that's difficult also because of my inattention. It's this trying to do more than one thing at once. I joke that I don't like to be alone with my thoughts, right? So I'm never just walking or just folding laundry. I'm also listening to a podcast and doing that task. So it's this need for a lot of stimulation. So we can both be overstimulated and understimulated mentally or physically. And this looks differently across the lifespan, which I think is important to realize as you work with adults. So in preschool, often those who have ADHD are going to be identified only if they have big external differences. The cannot sit at circle time, right? Are not going to play with just one activity. They're bouncing from activity to activity really quickly in a way that's significantly different than just your average 4-year-old. As they get into school, those behavioral differences can relate to academic difficulties, not necessarily because of any cognitive um, deficit or learning disability, though sometimes those can overlap, but more of just that inattention impulsivity. And that can also lead to poor social interactions and peer acceptance. In adolescent years, those academic difficulties compound. They then often may have lower self esteem because they've had a lot of really poor experiences, right? If you think about it similarly to students with learning disabilities, or maybe they've had a lot of interruptions with school because they have been suspended a lot or just truant. Um, Often they're not going to be able to cope with daily tasks, and it might lead to some occupational difficulties because of their difficulty maintaining attention, sustaining attention to task, for example. And then in adults, this is going to look like maybe not being able to cope with those daily tasks. So as our responsibility increases, it's then going to increase the things we have difficulty with. We may have relationship problems as a result, high rates of unemployment, and alcohol and substance abuse to regulate the dopamine and how we feel. So a related disorder is autism spectrum disorder. So I think the awareness of autism is greatly increased. And so, but so have the misconceptions. So autism is characterized currently by two things. So the first is deficits in social communication and social interactions. So this might look like reciprocity of understanding what you're thinking and feeling and being able to match that, as well as being aware that the way others think and feel and perspectives and experiences are different from their own. And we call that theory of mind. That's going to impact academics, especially in something like inferencing, understanding author's purpose, um, motivations of a character, because it's different from their own. And then that's might lead to difficulties in developing, maintaining, and understanding relationships. And then the second component to the current diagnostic criteria is restricted repetitive behaviors. This is going to look very different, but the sort of general way that this looked is some stereotyped or repetitive motor movements, use of objects or speech, insistence on sameness. So maybe some inflexible adherence to routines or ritualized patterns. I expect for these things to happen in the same order every day, and it's distressing when it doesn't. Individuals might have highly restricted or fixated interests that are abnormal. in intensity or focus. I always say I love doing professional development because it means I get to talk about my perseverative interest topics, right? I have a captive audience. Um, but individuals with autism might not be able to realize when their audience or the people they're talking to, if it's not in this lecture style setting, when they aren't interested in that intensity or focus. So that then impacts their social communication, social interactions. And finally, it is related to hyper, so too much, or hypo, too little, reactivity to sensory input, or maybe an unusual or abnormal interest in the sensory aspects of the environment. So we're learning more and more about how individuals with autism experience the world, and just their differences in the sensory input. So things might feel different, sometimes better, sometimes worse. For example, many individuals have difficulty with fluorescent lights, might have very, very hyper aware sensory input to sound. I think that that's one of the stereotypes, right? That people with autism don't want loud environments. That's not true. It's not a big deal. Some, if you're in an environment with, right now with fluorescent lights, I'm going to be quiet for a couple seconds. See if you can hear the light. I can, and here, and that might be distressing to some individuals because of their hyperreactivity. So a lot of these behaviors and characteristics overlap with many other things, right? So you can see here in the middle this autism spectrum disorder, and it relates to social anxiety. Some who may have just a social impairment, maybe some restricted interests where certain social situations are going to give them a lot of anxiety. You could have that and not meet the other criteria for autism. There's a lot of overlap with ADHD, so I'll talk more about in a minute. Because of this criteria of deficits in social communication, social interactions that often impacts language, individuals with autism are going to have some sort of speech language communication difficulty. So there's always going to be that overlap, but you can have that in other things, right? And then repetitive and restricted interests. We know that OCD is intrusive compulsions or thoughts, right? So compulsions to do something or thoughts that are repetitive. Individuals with autism can also have OCD, but OCD doesn't always mean that you have autism. So there's lots of overlapping difficulties that you may see in the individuals that you work with, whether you're aware of what their disability is or not, to think about. Here's just, I love graphics and graphic organizers. So here's another way to view it from Rosen, Lord, and Volkmar. So individuals with autism have said they have social communication deficits, and then these restricted interests, repetitive behaviors. Related skills, you notice nothing with autism had to do with their cognitive ability. That's not a part of the diagnostic criteria. And yet we know that there are individuals with autism who also have a cognitive disability. So they could have mild to borderline intellectual disability, but there are also those at the other end of the curve who have above average intelligence. And then, it's the full spectrum. So all of that depends. And certainly your intellectual abilities impact sort of these other areas. Language skills is another area that's impacted in different ways. So some individuals with autism might have very fluent language. So the actual ability to communicate using spoken words might not be impacted. They may have a different prosody. So maybe like a sing-songy voice, or maybe there's not a lot of changes in their intonation. All the way to those who have minimal to limited speech. And then adaptive functioning. So individuals who are, totally independent, live on their own, have great jobs, all of that, to those who require substantial support in various aspects of daily living. And what I want you to see is these are three different things, and you can have a whole different combination. So we might have individuals with above average intelligence but limited speech, and require substantial adaptive functioning help. Um, but that but they have this high cognitive ability, right? And so what's so great about autism is that there's such a variety of ways that it presents, and these individuals have such great strengths and abilities. But often in society, we judge based on some of these outside other things. So we see an individual who might need to use AAC to communicate, or have limited speech, and might require substantial support with adaptive or daily living skills. And then we make ableist judgments about what their intellectual ability is. Or we have this thought of you need to have average to above average intelligence. And we devalue people who may have a cognitive disability. So the current prevalence estimate is that 1 in 54 children are diagnosed according to the CDC. And this is if we combine both genders. But individuals who are male are 4 times more likely to be identified. I don't think the verdict is out on whether the prevalence rate, like how often it actually occurs, is higher in boys, but the way that it manifests, what the behavioral symptoms are different in boys than in girls. Our specific cause, it's unknown. Currently, science says that it's a mix of genetics and environment. There are some risk factors, male being one of them, family history. So similarly to a learning disability or ADHD, it's genetic. There are other disorders that often occur alongside autism. So Fragile X, tuberous sclerosis, and Rett syndrome, which Rett syndrome only affects females. And then some thought about perhaps premature delivery. We're still not sure about that. But what do we know does not cause autism? And that first is bad parenting. And you might kind of say like, oh, well, of course, like who would think that? Well, scientists used to. There was a term called a refrigerator mother, and mothers were blamed for their children having autism. You were cold, refrigerator meaning you were cold. You were cold to your child. You didn't love them enough. And that's why they've developed this way. And that was, up to the 60s, 70s. And so if you're working with adults or family members, it's important to realize this history and how things have changed, because it might impact their family dynamics and the feelings that they have about disability, about school, and so forth. We know that food allergies don't cause autism. Many people with autism have food sensitivities or allergies. We know that, like gut-brain connection. But gluten doesn't cause autism. If it might exacerbate symptoms. So, like, what happens to you when you eat food that doesn't make you feel good, right? It impacts all of us. And so it might be they have food allergies or sensitivities that do have behavioral implications. We know that things like red dye or any artificial food coloring impacts behavior, ADHD as well. And that's why a lot of other countries have banned them. The intelligence of a parent is not going to cause autism, and vaccines do not cause autism. I want to go back for a moment through sort of the history of diagnosing autism. When I presented at ASA Florida, was that just last week? Last week, this was of particular interest to the group, so I wanted to bring it back here. And again, I think it's important because you all work with adults in a wide variety of ages, and so their own experience with their disability or even awareness of their disability is going to differ based on what things were like at the time and where they lived. So the DSM, if you're familiar, is the Diagnostic and Statistical Manual. We should call it DSM because that's a lot of words. And that's what we use or what physicians and psychiatrists, psychologists use in diagnosing mental conditions, of which autism is one. And so we are now on our DSM-5. So I'm going to take you on a journey. The first DSM was published in 1952, the second version in 1968. There is no such thing as autism, right? So autistic-like behavior in the most extreme sense was mentioned in childhood schizophrenia. So many of these individuals were institutionalized or treated with the, pharmaceuticals that we had available at the time. In 1980, the DSM-3, this was the first time that autism was uh, officially a thing, we could call it. And so it was categorized three ways. One was infantile autism, so the onset before 30 months. Childhood onset PDD, that stand for pervasive developmental disorder. And that's kind of the onset was after 30 months, or how the family perceived and recalled it. And then atypical autism. And that was the individuals who only had social and language difficulties. In 1994, when the DSM-4 came out, again, all of these conditions were under one umbrella, pervasive developmental disorder. And that's where, again, we had some recategorization. We had autistic disorder, the onset before 36 months, so children. PDD NOS was like, we're not sure. It's just a pervasive developmental disorder, not otherwise specified. Asperger's disorder, and then childhood disintegrative disorder. So autism kind of was under one of these umbrellas. And then we had a long time before another DSM, and it was in 2013, and that's the DSM-5, and that's where we are right now. And so we now have autism spectrum disorder, characterized, as I went over a few minutes ago, deficits in social communication, social interaction, restrictive repetitive patterns of behavior, interests, or activities. And it is now categorized in 3 levels. So it's either considered level 1, 2, or 3. And that was based on the level of support an individual needed. And this is when sort of in the popular mindset or commonly heard, like they got rid of Asperger's, like Asperger's isn't a thing anymore. And that's not really what happened. It's more of, as the science developed, as we learned more about these individuals, and what helped with that is that DSM-4, like identification more broadly. We realized that they have things that are more alike than not. It's just degrees of support needs. I also like it because I think it's a pretty positive way to view individuals as far as thinking how severe is their disability, rather thinking about it as how much support do they need. So we didn't get rid of Asperger's. Those individuals are still kind of counted, but also Hans Asperger was a Nazi, so we also don't use his name. And then there are these individuals that are identified with just a social pragmatic disorder, and that's really just the social and language difficulties, not so much the restricted behaviors, interests, or activities. So what we see as far as the prevalence estimates and the diagnosis, I think pretty much everybody's aware, either from hearing in the popular press, from your work roles, your family life, being in the community, that the autism is on the rise, right? But what that really means is we have changed the way that we identify it. And we've changed, what bucket we put these people in, right? So if we go back to the DSM-1, these individuals who had maybe the most extensive support needs were in an institution. So no, you didn't see them. They weren't in your classes. That's because schools didn't have to educate them. It's not because they didn't exist. And then we just didn't have the categories of what to say, so it's not necessarily that something has happened that's causing more individuals to be born with autism necessarily. We don't know that, but rather we're identifying them. And the good news is we're identifying them earlier. So children are being identified much earlier. And that's good news because they're getting more intervention. They're getting special education services. They're getting speech language therapy, right? And ABA therapy to build daily living skills and reduce the impact of those behaviors. And that's good news. And that's going to be good news, as those individuals go through the school systems, because they're going to have more skills maybe than adults in the past who didn't have access to that. Similarly, right? So here's how you can see the difference in prevalence. So if we see this, the overall rate, it is really skewed when you see the difference between how many boys are identified versus how many girls are identified. So for every one girl, the most recent estimate is that 4.1 boys were identified with autism. And that's because it presents differently. Often females are really good at what we call masking. So it's this I can see how you are behaving. I can mimic and copy in a way that helps me sort of pass. Whereas it's not genuine. It's not really how I feel. They may have a lot more of those internal difficulties, but presents differently than boys. So we're going to talk more about this I think it's in January when we talk about neurodiversity. So I'll keep going. So this is what people often think the autism spectrum looks like, right? We think that we have people who are a little more autistic and a little less autistic, and here's kind of where they fall. And especially in our previous diagnostic criteria, it led to this belief. But this isn't really an accurate, even though we say spectrum, this is what the light spectrum looks like. What it actually looks like is you can have various degrees of these things. So your eye contact, you might have individuals who making eye contact is not a big deal, and then others where they're going to have to really focus on it. And I've had individuals say, like, I'm either going to look you in the eye or I'm going to listen to you. I can't do both. It's hard for me to do both. They may also have perhaps aggression as a result of communication, language, sensory difficulties, depression, abnormal or flat speech. Some individuals might have perfect prosody or pretty close. Maybe they've had great therapy or they've learned, and others who struggle. So when you think about this, all these different degrees of how autism looks, this is what actually autism presents at. So Birch is to credit for these visuals, but I think that when I saw this, it was really helpful of like, yes, that's what we mean. You may have heard the phrase, when you've met one person with autism, you've met one person with autism, right? Because while they fall into these DSM-5 categories, the way that it looks, I like to call it like the flavor, is different. And so people have different support needs. Neuroclastic, which is a great, if you're on social media, they have very good content that they put out on Instagram and on Facebook. But here's some other ways we can view that spectrum of difficulties, right? So it could be related to pragmatic language, the social communication, how both me having emoting or demonstrating my communication with you, but then also understanding what you're doing and why. So small talk, nonverbal cues related to social awareness. So can they pick up on etiquette incidentally, or more likely, we need to make things really explicit. A narrow focus, difficulty with task switching. So you may, in the classroom, this might look like insisting on finishing a task before moving on to the next task. Information processing as well. So taking in new information, seeing, where does that fit in my schema, and how can I generalize and transfer that? Sensory processing, as I talked about before, the being hyper or hyposensitive to stimuli. All of us have had times where we use the example, hypersensitive to stimuli. So if you can think of when you feel, if you're a mom, I felt this like touched out feeling, or if there's just too much noises and chaos. Some of us are more sensitive to that than others. And then think about, what's your internal state? How good are you at self-regulating, at communicating, doing a difficult cognitive task, tolerating that distress, right? None of us are. And then some neuromotor difficulties. So we also know that individuals with autism might have an abnormal gait, so much more common to walk on their toes, we call it toe walking, maybe difficulty understanding like where their body is in space. So again, these are not everybody might have all of these difficulties, but some combination of them. So I want to then think about, because there's a lot of overlap between ADHD and autism. So I often get asked, like, what's the difference? One difference is the age of diagnosis. So ADHD diagnosis typically waits until the school years. So characteristics are often noticeable before 2 years old. In autism, though, most often, certainly if those individuals only have some social difficulties, it might wait until school age. And then focus. Focus is another area of commonality. So, and individuals with ADHD can be easily distracted, difficulty sustaining attention to task until completion, and perhaps hyper-focused if that topic is of interest. Individuals with autism similarly are more likely to be over-focused, might have a difficulty transitioning to the next task, especially if you're going from a task they like, or if they need to go from a preferred task to a non-preferred task, or if they have not finished, right? We might really, really want to be finished, and perhaps be inflexible in routines and preferences. So I want to move on now to thinking about strengths-based approaches to learning and to teaching. Really quickly, I'm going to, there are marks on the screen I'm going to try and get rid of. I'm not sure why those are happening. Okay, so before I talk about the strengths-based approach, I want to be really straightforward with what my beliefs are about learning. I think that whether we are explicitly aware of these or implicit, not aware, our beliefs about learning, the purpose of school, impacts all the decisions we make. So I want to be really transparent about sort of my positionality as far as my beliefs about learning. So the first is I think that all students, whether you're thinking about a preschool student, an 8th grade student, an adult in CTE, everybody can learn without being taught. But effective instruction helps us to learn more and retain it longer, right? So I come from the perspective of wanting to make sure our instruction is robust and effective as possible, right? I think more learning is better than less learning. And that relates to what strategies we use and how we prioritize things. I think that what teachers do and don't do influences student learning, right? So each of us make decisions, and we have to make so many decisions as teachers, whether you're teaching children or adults, regardless of the setting or how many you have. And that's part of what makes teaching exciting, but also exhausting. It's constantly taking in information and making decisions. I think that the most effective teachers focus on alterable variables, meaning what are the things I can do something about? I cannot do anything about whether somebody wears their glasses or their hearing aids. Can't do anything about whether they take their medication. The fact that an individual has dyslexia, like that is what it is. But I'm going to think about what are the alterable variables? What are the things that I can change about my instruction or the instructional environment in order to increase learning? I also think that effective instruction is evaluated by its outcome. So are they learning more, right? Have skills increased? I think that teaching explicitly is better than roundabout teaching, having students struggle to find the answer on their own. I think there's a place for problem-based learning and inquiry and all of that. But when we have learners who are struggling, my phrase is that people who are drowning don't have time to perfect their strokes, right? So if our learners are drowning, figuratively, we need to find out what the best way is to get them swimming the quickest, and not focusing on maybe some of those other superfluous details. And I think that our effective teaching practices need to be identified by their function, not their form. And what that means is what the purpose of them is, because people do different things for different purposes. Okay. So that means part of what makes teaching, like I said, all those decisions you have to make, it's not a scientific formula, right? And it depends in almost every situation. So there's the context that we're working within. So each of you, whether you are in Miami or Pensacola or Mariana or Gainesville, right? Very different context. Your students are in different contexts. So that's going to impact everything. There's also like what the research says, and we're learning more and more about, for example, how to teach reading. We then have our learner characteristics, those that we're aware of and those that we're not. It's going to impact how much information we have to make a decision. And then also resources and expertise of ourselves as the teacher, right? So like what skills do you have? What tools do you have in your toolbox? And what resources do you have available? And all of that together influences how you make decisions. And I hope that over the course of this webinar series, I'll be able to increase the skills that you have in these different areas. So while can't tackle all of that in 90 minutes, one thing that we can talk about is how much words matter, and the words that we use to talk about individuals with disabilities and ourselves is important. So first option in what's most common is focusing on deficit areas to help individuals conform to like neurotypical or the normal expected uh, ways of being, right? And that comes from our medical model of disability, where we really do focus more on like what is the deficit and then what's expected. A second option, though, something else we could do is see disabilities as another way of being human. So it's looking at, there's a wide variety of abilities and strengths and needs, and we are all different. It's not denying the fact that a disability is what it is, right? It's not just rose-colored glasses. But I'm going to give you an example of what this can look like. So the way we talk about an individual, you could say he's obsessed with cars. Or we could say he's passionate and enthusiastic about cars. That paints quite a different picture, right? One is when we say you're obsessed with something, it's generally not a good thing. Or we could say he's passionate, enthusiastic, right? He has severe meltdowns about things. Or is it that he feels emotions intensely? This would describe my son. You could say, oh, he's so rigid with his routines, or he prefers consistency and sameness. Who else here prefers consistency and sameness? Me, right? Everybody likes to know what to expect. There's just a variety in how much we are flexible in that, and how much does it distress us. One that I feel like I have to mention is when we say someone is low functioning, that really establishes what somebody's expectations are for you, right? Or could we say they need a high level of support, right? Because then we're focusing on what they need to be successful, not whether or not they're going to be successful. So this goes over here. We often think of people as on this bell curve, like you have relatively less skills and relatively more skills and typical. Instead, I want us to see that the variability in us is a natural part of the human condition, and it's part of what makes us great, right? We have people with a wide variety of skills and very different um, experiences and strengths. Each of us have strengths and weaknesses. Something that I have very poor visual spatial skills. I am not very good at figuring out like how things work, like physically. So nothing will get me more frustrated more quickly than a jammed copier, uh, even a stapler that I can't undo. I just don't have skills in that area. And so if I had a job where it was required that I did that all the time, or if school was based on those type of tasks, I would seem more disabled, right? But instead, I chose a job where that's not really required, or I can ask somebody for help, right? I chose a job where I get to talk and write things I'm good at and I enjoy. So it's not a judgment. It just is that we have different skills. So when we think about what is a strengths-based teaching approach, it means that we recognize strengths to see how individuals are interpreting words, ideas, their environment, and you. So we're not focusing on, oh, he's so, rigid with routines, but rather like something really strong then is that once I've shown this individual how to do something or he's learned a procedure, he has that procedure down. That's a strength. Who compared to maybe some of your other students who we're following the same thing over and over and over, and they are not able to recognize those patterns and internalize them. We also want to learn about our individuals' interests to help them develop skills to do more of what they enjoy, whether that is for a career or leisure skills, relationships. There is more to adult life than work. Work certainly is important, and being like realistic about the society that we live in, but also we can think about how can we leverage their strengths and their interests to help them have a higher quality of life, to enjoy what they're doing. And then we need to understand what need a behavior is fulfilling. So anything that we do, it serves a function, right? So trying to understand, why something is happening, what's the need that it's filling, and maybe is there another way to fulfill that need, or maybe I just let that go. What is not strengths-based teaching is learning styles. Even though it seems on the surface like, well, I want to know how my student learns, what their preferences are. So let me figure out what their learning style is and then tailor instruction to them. On its face, that seems like it makes sense. But, and by learning styles, if you're not familiar, I'm actually happy. But learning styles is assessing a person's intelligence, finding what is dominant, like, oh, they're an auditory learner or a visual learner, kinesthetic learner, and using that to develop instruction. It's based off of Gardner's theory of intelligence, which is not scientific. Anybody can come up with a theory, by the way, and anybody can publish a book. Certainly he convinced others that it was true. But the original sort of like types of intelligences were these. The problem is then you may look at your multiple intelligence profile and see, where you fall. Where this doesn't hold is any experimental studies where they have given people a learning styles assessment and then divided the groups and, for example, presented information auditorily to the auditory learners and visually to the visual learners. You would think, right, that then the auditory learners would do better on that and the visual learners would do better on their task. And that never holds true because some types of information just have to be taught a certain way, right? Listening to music isn't going to help you identify places on a map, for example. Again, where this is coming from is this acknowledgement by educators that individuals vary. There's variability and there's preferences, and we want our learners to be engaged We want them to feel successful, and it comes from this desire to do just that. But this isn't the best way to tailor and think about individual strengths. Instead, later, might be our last webinar, we're going to talk about universal design for learning. And UDL is a way to think about everybody's needs and strengths and barriers to learning, and how can we proactively design a learning environment to address all of those things. So UDL is a framework supported by research that we can use to make sure that our instruction and our assessment is accessible to everyone. So stay tuned on that one. Here's how a few ways that you can explore a strengths-based approach. One, just think a little bit more about your students. Now that I've kind of given you a lot of information about individuals who may have identified or non-identified disabilities, think about what are their needs and what are their strengths. Getting to know your students to find out what their interests are can help you to focus on that. You don't want to, though, be unnecessarily restrictive or prescriptive in how students demonstrate learning. Certainly, if they have to take a GED or another assessment, there's only so much flexibility, right? And approved accommodations that are difficult to get. So sometimes, yes, we need to build up test-taking skills for our students to be aware of how they are going to be forced to demonstrate learning on one of those standardized assessments. But not everything has to mimic that. We can think about what are flexible ways that we can present information and have students demonstrate their learning that isn't just drawing on their difficulties. Embracing routines and structure, increasing the structure and the routines of your class will help each one of your students, regardless of which of the disabilities I talked about today they have. We also want to be really clear and explicit in our expectations, in teaching, in learning strategies and needs. So that we're not leaving anything up to interpretation. I'm a big Brene Brown fan, and a common phrase that she says is clear is kind, right? So we want to be as clear as possible. And then we want to focus on what we want to focus on and let go of the rest. And what I mean by this is think about what is the task, what is the learning objective? And focusing just on that. So for example, if a learning objective is maybe you want your students to learn how to take notes. That's one example. Just because if you're wanting them to learn how to take notes, doing that at the same time as having to listen to you talk over the PowerPoint or notes, which is common, or taking notes to learn new content, you're asking them to do two difficult things at one time, especially if they have a learning disability, language, processing disorder, autism spectrum disorder, ADHD, where they're, where do you want me to put my attention? Another example is handwriting or spelling. So does everything have to be a permanent product worksheet? Or can they demonstrate their learning through discussing or showing something? And this leads into this socio-ecological view of disability. So if we think about a match between the demands of your environment and your own personal competence. So do a little reflection on yourself, what your life has been like in the past 2 hours. You knew at some point you signed up for this webinar, or if you're watching a recording, you access the recording, right? You went through the steps to do that. You logged into Zoom. You're here now. The demands of this environment matches your personal competence. You're here. Sometimes our competence hasn't changed, but the environment has changed. Our demands have changed. COVID is a huge example of that. Those of us in education who had to switch to virtual, all of a sudden, like my skills are the same and the environment is now way different. I'm having to learn how to engage people virtually, how to manage multiple Zoom meetings. And so there's a mismatch. Sometimes the environment can stay the same, but something has happened to impact our personal competence. This might be an illness, a traumatic event. It could also just be like the difference between my personal confidence on Mondays and Thursday afternoons or Fridays is quite different, right? So depending on what's happening within my internal state or emotions, it's going to impact uh, what that split is. But for people with disabilities, there's often both are true. Their competence and their environmental demands, there's a huge space between those. So what the socioecological view of disability does in a strengths-based approach, first of all, it does not deny that individuals have limitations or deficits in relations to others, right? There are disabilities. So we're not pretending that because there's this view that if you just fix the environment enough, if you just make the environment accessible enough, there really won't be disability. And I don't prescribe to that belief. It does call, though, for thinking about competency holistically in relation to environmental demands. So we want to think about this mismatch and how can we think about what the environment is, what are the demands, and what the individual skills are. And are there things you could do in your classroom to decrease the demands? Maybe there are fences. Think about the very first prompt I asked. What are the barriers your students face? And could we maybe remove some of those? Or do some of those not need to be there? Or, and, and what about the individual's competence and skills? How can we increase those so that it's this both and situation? So as I leave you each webinar, I want to leave you with some resources that you can go to if you want to learn more. And one fantastic resource is the IRIS Center. So the IRIS Center is a federally funded center out of Vanderbilt University. And they have, I mean, you can see from the screenshot, this was only A through L. So they have a ton of topics. And just going straight to the IRIS Resource Center can help you to identify those. And so they have case studies and modules you can work through at your own pace. Some of those are available for like CEU type credit. So I want to make sure everybody knows about this. If you want to maybe do some learning on your own or along with colleagues that you work with. And then I want to tell you about some related professional organizations. So obviously, the Florida Department of Ed does a fantastic job with adult ed. I think they're really a leader in the country in this area. And ACE as a resource is also fantastic for staying up to date and responsive to the needs of practitioners and students. Another professional organization that you may not be familiar with, if you haven't been in K-12 or you aren't coming from a special ed background, are related is the Council for Exceptional Children. So this is the professional organization for special education, disability education. And then they have these subgroups, right? And so two subgroups that I want to highlight today are the Division on Autism and Developmental Disabilities, or DAD. I'm currently on the board for another, I think, 2 months. And I want to plug, our conference is in Florida most years. And so we have an annual conference that's focused on research-informed practice. And the intended audience are educators, professionals, families who support individuals with autism and intellectual disability. And you can go to their website to find out more information. They have lots of practitioner-friendly articles and briefs. Their YouTube channel has some like real quick instructional videos for strategies. And then the Division for Career Development and Transition, DCDT, is a second subdivision. And so they're focused on transition to adulthood and supporting individuals with disabilities enrolled in post-secondary education. And their conference is next week. I guess I'll be there next week in Little Rock. But they have one every fall. And also their website has great resources where they've taken, empirical research and translated it into like the so what for professionals. So that comes to the end of our time today. I look forward to seeing you all in November. As we go into our next webinar. Please keep in touch. If there's anything that I can do to support your practice, various ways to get in touch with me.
Jenny, thank you very much. Great job.